Good morning, one and all of you, and my special thanks to Dr. Mahipal to include me in his course. Going on to the topic, surface ablations. Essentially, Excimer and PRK were the ones which had opened up the realms of refractive surgery. However, they got temporarily stumped because at that point of time there was not enough understanding about PRK and the limits of corrections, and the protocols were not exactly evolved, and haze and regression continued to be the bugbears at that time. But if you look at this growth graph, as you can see that there is a gradual peak in the laser vision correction procedures up to 2007. But after 2007, there are different options which are surfaced, like surface ablation got rejuvenated, there were phakic ICLs, and different options came forth for refractive correction. And this was a similar pattern which was seen in UK too. And what was interesting was that in a small group study, between 4 to 7 diopters, they found there were about 300 eyes which had iatrogenic ectasia. And so there was a whole lot of information, explosion of information, and this sort of tempered our understanding, and the ground rules got to be laid. So there were some limits which were laid down for PRK or surface ablations, that we do not treat over 6 diopters of myopias, avoid treating deeper ablations, stick to less than 80 microns, and avoid small optic zones. Again, it needless to add, we have to be very cautious that these are already thinner corneas which come into the realms of surface ablation. So you do not overtreat these corneas. You should leave at least 300 plus residual bed to avoid iatrogenic ectasia. So there were different modes of treatment which evolved. The spelling is wrong. LASIK, wherein you use 20% absolute alcohol, and first, of course, you copiously irrigate the conjunctival sac with BSS, whichever option you do. And then in LASIK, you place a trephine on the eye and expose it to this 20% absolute alcohol for about 20 seconds, wipe it off, and then this loosens the epithelium, and you're able to separate the epithelium right up to the basement membrane and creating a cleavage. In EpiLASIK, a plastic separator was used to bring about a separation between the basement membrane and the Bowman's membrane. And in the Wavelight PTK, or which is also there in the other laser machines, use a laser to do a transepithelial removal of 50 microns and then go ahead and do the refractive ablation. Again, whenever you're doing a surface ablation, we need to remember that we need to add a 0.5 for the overcorrection, because there is always some amount of a hyperopic shift which is possible. The main challenge for surface ablation is addressing the pain, which has to be adequately addressed. So one way is to place a chilled ice pack for 15 minutes prior to the procedure, copiously irrigate the eye with chilled BSS so that it chills the pain causing nerve endings, and place a BCL after you've done the procedure, which allows the epithelium to reepithelize and thus takes care of the pain. As far as wound modulation is concerned, again, there was a whole lot of understanding, and we came to a consensus that we would use about 0.2% concentration mitomycin for 30 seconds. Some use it longer, but I have found that I have stuck to 30 seconds in all ranges of refractive error and do not have a single case of haze in our study. Topical steroids, I prefer to use it over 3 months in a tapered regime, and vitamin C, which acts as an antioxidant on a BD dosage for 6 weeks. We need to keep in mind, because we're using steroid drops for a longer time, and because these eyes are myopes, there could be some steroid responders hiding in somewhere. So we need to review these patients. Initially, of course, have a look at the disc, and if it's a suspicion of some glaucomatous changes, do not take them up for surface ablation. At least have a baseline OCT and fields done for these patients. Again, if a person has stopped the steroid drops in the initial part of the treatment, he could develop a nebular haze. So you could restart the steroid drops if you have noticed it in the early post-op period. Really, you could scrape the scar tissue with a PTK and apply mitomycin, and there is some resolution of the problem. Again, PRK has multiple roles to play. It is actually a hero when it comes to secondary flap complications. If you've had a vertical breakthrough and you cannot complete that procedure, you could do a surface ablation. If it's a very small eye and you're not able to place your microkeratome and you get an incomplete flap, you could do a surface ablation. Again, if you've had a buttonhole with a microkeratome, then again, you could do a surface ablation as a secondary option. And any of these flap complications, primarily if you have gone wrong and you have not understood the topography and you have used wrong the white to white of the microkeratome, if it's a steep or a flat cornea, you get these problems, but these could all be secondarily treated with surface ablation. Against a post-cataract enhancement, the cornea is on the thinner side, you could do a surface ablation. And these are older people, so the dry eye issues could be there. So it's better to use a surface ablation option as compared to a flap with a femtosecond laser or a microkeratome. Again, this was just once which I did it. I wouldn't say that this should be a standard modality of treatment, but the patient had come just for a couple of days from abroad and wanted a microkeratome procedure only. And what happened was, initially itself, when it started the procedure, was an incomplete flap. So it hardly had run 1 second or two. So put the flap back, and I did the surface ablation the same sitting. And he did come up for follow-ups and managed to remain his refractive accuracy. It is actually came in as a boon for a SMILE challenge. It was my initial third case when I had a very small refractive error of minus 1.25 to be treated, and we needed a very thin lenticule. I wasn't that aware that you could increase the thickness of lenticule to up to 30 micron, and ended up with a problem in dealing with the removal of the lenticule. So nowadays, what all of us would do is, if you have a very small refractive error which is being treated, you could increase the thickness of the lenticule right up to 30, which allows you ease in removal. There were huge problems here. There was a lot of OBL here because there was compression. The energy levels were not optimal. So the lenticule was very thin. So removal was quite a challenge. I did all techniques of trying to remove it and finally gave up. And this is how the refractive error was. Initially started with a 1.25. And this is how it presented. Here again, what I want to tell is, I could go ahead and redo the procedure after 3 months once the refractions and the topography stabilized, and the patient did very well and ended up with a plano refractive error. Going on to another case, this was a patient who had a normal topography for which I did a SMILE for the first eye. But when you look at the second eye, there is this nebular opacity here. You know it's not an ectasia you're looking at, but definitely there was something suspicious, and the Bellins again showed a whole lot of red flags here. So in this particular case, the first eye I did SMILE, and the second eye, because I wouldn't want a vertical breakthrough, I went ahead and did a surface ablation. Going on to topo-guided treatment, this was a patient who had a normal -5 myopic refractive error and a normal topography. But it evidently, because the microkeratome was not placed so that there was more of the superior limbus shown, inferior limbus shown, he ended up with a low hinge and was very disturbed with the diplopia and the hazy vision. So in this particular case, you can see that there is this flattening where there is the hinge was there. So in this particular situation, the Q value was within normal limits. So all that I did was just did a topo regularization of the cornea. That is the 0.5 and the nomogram correction. Just I did a 0.75 of refractive correction. And this is how his topography regularized. He just had a small plus 0.5, but was very significantly happy with visual outcome. This was another patient who came in for, again, a refractive correction, wanted a microkeratome procedure, and had a free flap. Probably the limbal orientation was not appropriate while repositioning the flap, and the patient had significant astigmatic refractive error. Again, in this case, there was no need to do a Zernicke's neutralization. And what was done was just that 0.5, which you need to overcorrect when you're doing a surface ablation. This was done on a topo-guided mode, and you can see how the topography had regularized. You can see it on the sagittal curvature map. And then the next eye shows that the correction was complete. The patient had plano 6.6. We also have come to understand more about biomechanics, but we're still, it's like a tip of the iceberg. But Ora and Corvis were some other gadgets which came forth, which told us something about the hysteresis of the cornea or the deformation which occurs, and it helped us to measure the biomechanics, although the results were not very consistent. But what we did understand was that surface ablation was definitely needed, but more so, you could combine it with cross-linking in suspicious cases. because we had come to understand that definitely cross-linking restored the strength of the cornea or the tensile strength of the cornea and improves the flap bed adherence. So keeping this in mind, we could look at combining cross-linking with refractive correction, and we came to realize after numerous studies that there was no refractive effect like haze or scatter, and the long-term effect of progressive flattening did not occur. I would corroborate more to it as I go on. So when you're doing a surface ablation, if it's a thinner cornea and a refractive error which does not justify that thin cornea, assuming I have a 460 micron, I have a -3 diopter, no way would I do a -3 with a 460 micron. I would even suggest a phakic ICL at that point. But when you have a cross-linking supporting you, you're able to consider these eyes. Again, when you're doing a retreatment is when you could think of combining it with cross-linking. But whenever you do a surface ablation, I would like to combine it with mitomycin C, even if I'm doing a low refractive error. But if I were doing a cross-linking along with a refractive procedure, I would not use a mitomycin, which is an important point to note, because cross-linking itself causes apoptosis of the keratocytes, and there is no haze. This is one example of PRK extra, where you can see on all the maps, the elevation points are elevated. There is some amount of infrared temporal thinning. There is odd oblique astigmatism shown on the sagittal curvature map. You can see the Bellin shows all the red flags. Again, a similar milder picture in the left eye. This is a case where I would combine it with cross-linking. But when I'm doing a cross-linking for a refractive procedure, instead of 5.6 joule per centimeter square, I would bring it down to 2.7 joule per centimeter square. I would first apply riboflavin for Vibex extra, wherein there is no dextran, but methyl cellulose is the vehicle. And I would apply these drops every 10 seconds for a minute, and then expose it at 30 milliwatts per centimeter square for 90 seconds. And we found that in many of our studies which were published, that these patients did very well. All of them ended with a plano refractive error. Again, the other area where you could combine surface ablation is where the patient knows he has keratoconus, wherein he would like to do, we would like to do some kind of a topographic regularization so that he was able to tolerate his contact lens better, or you could combine it with a toric ICL at a later date. Essentially, cross-linking, we all know, has a stiffening effect, but there is significant irregularity on the cornea. And if you could regularize this cornea on a topo-guided mode, you're able to do some amount of refractive correction at the same time strengthening the cornea. So essentially, you're doing a central myopic ablation and a mid-peripheral hyperopic ablation. And in two briefly information which I could give in this podium, you are essentially making it a flatter and a broader cone, wherein there is sort of a redistribution of the biomechanical energy. And this, once the treatment is done, if you cross-link it with CXL, then it sort of binds the power and regularizes the cornea. So going on to this particular case, this was the refractive error which the patient had. We need to keep in mind that we do not correct more than 50 to 60 micron of tissues removed. Here again, we do not play around with the Q value in this instance. We just do the refractive correction, what is possible, keeping in mind the amount of residual tissue. But here, you would do the full treatment of 5.4 joules per centimeter square at 9 milliwatts per centimeter square for 10 minutes. And definitely, the cornea definitely gets regularized. In some, you get significant refractive correction, but the patient is definitely happy with the quality of vision which he has at the end of the procedure. Would I do it simultaneously? Yes, one, to save time. The other is, it makes sense because cross-linking at the same time takes care of the haze. And if you have cross-linked the cornea and later, at a sequential treatment, you like to do ablation, you could never be sure about how the ablation is on a cross-linked corneas, and you do not have the nomograms for the same. So it makes sense to do the regularization and the cross-linking at the same time. So it's limitless what we could do with surface ablation. The scope is enormous in the refractive surgery armamentarium. But what we only need to know is it's a longer time recovery, and we need to give realistic expectations to our patient. Thank you.